So, as I was telling about the three entities PPRM, PRM and preterm labor. PPRM is preterm. Preterm means whenever it is less than 37 weeks, 37 completed weeks. Pre-labor means before onset of labor, and if at that time rupture of membrane, membrane means which membrane? Which membrane will be there covering the fetus in pregnancy? What other membranes are there? You must have learned it in the embryology and anatomy. It is amniotic membrane and chorion. Amnion and chorion are the two membranes which is covering the fetus, and if that is rupturing, then it is called rupture of membrane. So, preterm pre-labor rupture of membrane is called PPROM, and PROM is pre-labor rupture of membrane. Whenever it is 37 weeks completed, but before onset of labor, it is PROM. Then preterm labor is onset of labor after the period of viability and before 37 completed week. So, here onset of labor and rupture of membrane are two different. Membrane rupture can occur without onset of labor also. So, membrane rupture if it is occurring before onset of labor, then it is PPROM, and if it is onset of labor only, membrane is not ruptured, then it is preterm labor. I think it is clear to you. So, onset of labor, how will you know whether the labor normal labor has been covered till now? It started or not started? Onset of labor. So, if it is done, then tell me what is the signs of labor. How to diagnose labor in a pregnant lady? How will you know that she is in labor? So, there are some cardinal signs and symptoms are there by which you can diagnose it. So, no investigations are there, only clinical signs and symptoms by which you can diagnose. One is intermittent uterine contraction and associated pain. So, that is called as labor pain. So, when uterus contracts, it contracts in intermittently. It will contract, after few seconds it will relax, and there corresponding to that contraction and relaxation, there will be associated pain. Okay. Pain in abdomen and vaginal discharge. Vaginal discharge is also called as SHOW, SHOW, SHOW. SHOW is the discharge of blood and mucus from the cervix into the vagina. So, this is called as SHOW. Regular uterine contraction, pain abdomen, presence of SHOW, presence of bulging membrane, it may be there, may not be there. These are the signs and symptoms of labor. So, if those signs and symptoms are present, whenever it is less than 37 weeks, it is called preterm labor. Got it? So, first thing we will discuss about the preterm labor. Although preterm labor, PRM, PPRM are related, so individually we will assess the risk factors for each of them. So, what are the associated risk factors for preterm labor? There are many are related to pregnancy and many are related to the severe maternal illness. So, pregnancy means it can be pregnancy, fetus itself, or it can be uterine also. So, multipetal pregnancy is a risk factor for preterm labor. How it causes preterm labor, I will tell you in the next slides. Intrauterine infection, bleeding, placental infarction, premature cervical dilatation, cervical insufficiency, hydramnios, uterine fundal abnormality and fetal anomalies. These are the risk factors for preterm labor. So, here from the down we can say fetal anomalies. Some fetal anomalies that can induce preterm labor. Got it? So, those fetal anomalies which causes secretion of more amount of liquor or more amount of amniotic fluid, that causes over distension and cause preterm labor. Uterine fundal anomalies. Fundal anomalies like if there is septate uterus or bicarbonate uterus. So, in that case also there will be preterm labor, because the fetus will get less space inside the uterus, and due to less space it will try to contract and there will be uterine contractions. And all other things I will discuss in the next slides. Severe maternal illness like infection, if the patient is in sepsis or patient is having any other systemic infections, in that case also there will be more chance of preterm labor. Autoimmune diseases, gestational hypertension and gestational diabetes is known risk factors for preterm labor. So, here you can see schematically these are the causes of preterm labor, but many of those are common and many are not so common. So, common is the uterine over distension and infection. Infection is the most common cause of preterm labor, then uterine over distension, rest all other causes are less common. So, we will discuss how over distension causes uterine contraction. So, over distension causes expression of the contraction associated protein. Here you can see expression of the contraction associated protein in the myometrium, that is one of the mechanism. Another mechanism is excessive uterine distension leads to activation of the placental and fetal endocrine cascade. So, this is a hormonal cascade which starts due to the over distension. Due to the two regions, contraction associated protein or CAP and the endocrine cascade which is initiated, there may be premature activation of the inflammatory process, and that causes uterine contraction and preterm labor. So, this is the region you may be asked why over distension causes preterm contraction. Then infection, intraamniotic infection has been linked to the preterm spontaneous preterm contraction. Infection there in other part of the body may not be so relevant, but if it is infection in the amniotic cavity or the amniotic membrane, that causes preterm labor. So, how the bacteria or how the organisms gains entry into the fetoplacental unit or uteroplacental unit. So, here three routes are there. One is transplacental transfer of maternal systemic infection. So, maternal blood-borne infection that can come to the fetal circulation through the placenta. Another is flow of infection via the fallopian tube. Fallopian tube is patent. So, from the pelvis or from the abdominal cavity, that can enter into the uterine cavity. Then ascending infection from the vagina and cervix. Here this one is the most common. Ascending infection is considered today most common entry route in the pregnancy. So, it colonizes the decidua and membranes at the lower part of the cervix, and eventually it may enter into the amniotic cavity. So, what are the associated infection? What are the organisms associated with preterm labor? So, the common organisms like Streptococcus, Staphylococcus are not so much implicated for the preterm labor. So, in superficial skin infection, Staphylococcus, Streptococcus, those are more common, but genital infections are more due to the Gardnerella vaginalis that causes bacterial vaginosis, Fusobacterium, Mycoplasma hominis, Uroplasma uroleticum and group B Streptococcus. These are the 5 type of organisms that are more common for preterm labor, and these organisms are also responsible for PID in non-pregnant lady. So, PID, pelvic inflammatory disease, and preterm labor PPRM, there are some way related organisms are responsible. So, many factors which contribute to the genesis of the preterm labor. There may be presence of risk factor, but the onset of labor pain is related to these are the factors. So, if prior preterm birth is there, so then there can be chances of preterm birth in this pregnancy also. Suppose there is a spontaneous preterm birth in the last pregnancy. So, that this pregnancy may also land into spontaneous preterm birth. If it is induced one, indicated one or induced one. So, can anyone tell why preterm labor is induced? Why preterm labor is induced? Roll number 5 is there. Roll number 5. If no one is responding, 5 will be absent for today. Roll number 7. 5, 7, yes, 7. Do you know any reason why labor is induced preterm? Why labor is induced before 37 weeks? Yes? Rupture of membrane. Okay. If rupture of membrane, usually labor starts its own, or we have to induce it. And other common causes are if there is severe maternal illness, severe hypertension is there, and diabetic uncontrolled, and if there is IUD, intrauterine death, in that case also you have to induce the labor. Okay, sit down. So, if there is any abnormalities in the pregnancy, fetus or mother, in that case you may have to induce her before 37 weeks. So, any induced preterm birth may also have the preterm birth in this pregnancy, because the same risk factor might have recurred. Then spontaneous usually recurs, and lifestyle changes also induces preterm labor, like smoking, poor diet, illicit drug use, stress, heavy physical activity. These are the lifestyle factors that also implicated in the preterm labor. Some genetic factors are also there that explain the recurrent or familial preterm birth. Infection already I have told. So, apart from these two, another 3 organisms also there. Periodontal disease like gingivitis also highly significant in the induction of preterm labor. Interpregnancy interval, if it is long or short, I will go into detail about all these things that also causes preterm labor. So, prior preterm birth means around 70% of the prior preterm birth will also have the preterm delivery or preterm labor in this pregnancy. So, it occurs within 2 weeks of gestational age in which last pregnancy was delivered. Suppose in the last pregnancy it was delivered at 35 weeks. So, here in this pregnancy it may deliver by 33 weeks, 34 weeks or 35 weeks, or 2 weeks more than 35 weeks. So, around 2 weeks this side or that side there may be chances of preterm birth, and the cause of prior preterm delivery is also recurred. Suppose last pregnancy she had severe hypertension, this pregnancy also she may develop the severe hypertension. So, the cause recurs and the effect, the preterm birth, that also recurs. So, it recurs at the range of around 70%. Then certain pregnancy factors are also risk factor for the preterm birth, like threatened abortion. Threatened abortion means 75 roll number, preterm birth, threatened abortion 75 absent, 82, so threatened abortion means whenever you are 82, 82 or 72, 75. Tell me what is threatened abortion? Threatened abortion means when patients comes to you with some symptoms and signs which indicates that patient may undergo abortion or may develop abortion. Okay. But that is a threatened only. That is not a sure set that she will eventually land into miscarriage. Okay. Sit down. So, if in first trimester there is bleeding is there, spotting is there or bleeding is there, that is also called as preterm threatened abortion, and that threatened abortion is a risk factor for preterm labor. Then birth defects, already I have told certain birth defect can cause preterm labor like spina bifida, and then anencephaly usually causes postpartum pregnancy. Spina bifida, open spina bifida, meningocele, myelocele, those things causes preterm delivery. Then multipetal gestation causes over distension. Two fetus will be there, more liquor will be there, over distension is the cause of preterm delivery. Then lifestyle factors, both underweight and obese mothers both are more prone for preterm delivery. Young and advanced aged, this is again risk factor. Cigarette smoking, vitamin C deficiency, these are also risk factor for preterm delivery. Some evidence is there that working long hours, fixed night shift and hard physical labor can cause preterm labor, but it is not universally accepted, not proven with all the studies, but some studies show that these are the factors which can cause preterm labor. Other factors like periodontal disease already discussed, significantly associated, but till now it is not prevented by treating the periodontal disease. If interpregnancy interval is less than 18 months or 1.5 years or more than 59 months, around 5 years, then there can be more chance of preterm labor. So, then how to diagnose it? How to diagnose the preterm labor? So, these are the symptoms, these are the signs, and this is the investigations. So, symptoms like pelvic pressure, cramp in the abdomen, watery vaginal discharge and lower back pain. These are the symptoms usually indicates preterm contraction. So, pelvic pressure is the usual early symptom. Patient usually feel that something pressing over the pelvis, and eventually within few hours she may develop pain abdomen, she may develop vaginal discharge, or she may develop lower back pain. And in that case you have to see for the uterine contraction, you have to see for the cervical changes, cervical dilatation effacement. If those already started, then it is preterm contraction. So, you can see the cervical length by sonography, but usually labor diagnosis of is done by examination only. Then fetal fibronectin level can also be checked. If fibronectin level is increased, then it usually indicates preterm labor. So, how to prevent preterm birth or preterm labor? So, many methods are there, none of those are completely proven. One is cervical encirclage. So, this is a operative procedure. So, here we have to ligate or we have to tie a suture around the cervix. So, here you can see three methods are shown. These two methods are vaginal method, this is the abdominal method. So, vaginal method, one is McDonald circlage, which is put little lower at the cervix, and Sirotker circlage, this is little higher. You have to reflect the bladder and put the circlage. These two sutures are done by vaginal route, and another is abdominal circlage that has to be done through laparoscopy or through laparotomy. So, these are the three methods by which you can do the circlage, so that cervix will not open and preterm birth can be prevented. But here one thing you have to see it, that the fetus is not at compromise, neither the mother is having bleeding PB nor active contraction. If active contraction is there, still you are putting a sutures there, then the uterus or cervix may tear. But if bleeding is there and you are closing it, the blood may accumulate inside and resulting in death of the fetus. So, there are certain indication of cervical encerclage, like prior history of 3 preterm birth, prior history and the history of short cervix. Cervix length should be less than 2.5 centimeter, then only you have to put the cervical encerclage. And encerclage is usually put at 12 to 14 weeks of gestational age, but rescue encerclage, that is emergency encerclage, can be put up to 26 to 27 weeks. So, emergency encerclage means, suppose patients came to you with some dilatation, 1 centimeter, 2 centimeter dilatation. In that case, you can put a cervical stitch if there is no active contraction. If active contraction is there, you should not put the cervical encerclage. So, other methods are giving progesterone. Progesterone causes uterine quiescence. Quiescence means resting stage. By giving progesterone, the uterus comes into the resting stage. Then aspirin is also having some role in preterm birth prevention. So, these are the methods by which you can prevent it, but it is not always preventable. So, till now we were discussing about preterm labor and preterm birth. So, now the PROM and PPROM, these are the two entities. So, incidence of PROM or PPROM is 3% of pregnancies, and it causes approximately 1/3 of all spontaneous preterm deliveries. So, if the PROM, PPROM is the commonest cause of preterm delivery. So, once the leaking starts, many times it does not stop. Even if you ask her to lie down, if you give some medication, it continues to leak. So, this is the common cause of PPROM or PROM, common cause of preterm delivery. So, what are the risk factors? One is umbilical cord presentation or pull-ups. These are the risks of PPROM. So, if there is rupture of membrane, cord may come along with the liquor outside the cervix. So, umbilical cord pull-ups or presentation may be there, and cord may compress. Initiation of preterm contraction will be there eventually. Intrauterine and neonatal infection will be there if leaking is prolonged, and abruption can occur due to sudden decompression of the uterus. If liquor is suddenly coming out, then uterus will contract, and due to the sudden contraction of uterus, there will be shearing stress between the placenta and the uterus, and due to the shearing stress between the placenta and uterus, there will be abruption. PPROM is also associated with high neonatal mortality. So, because the fetus is preterm and preterm baby are associated with neonatal mortality due to many causes like infection, hypothermia, hypoglycemia, sepsis, those things will be there. Periventricular leukomanosia is common with PPROM. Bronchopulmonary dysplasia will be there whenever PPROM is very early, around 23 weeks of gestation if PPROM occurs, and the pregnancy continued for a long time, then in that case bronchopulmonary dysplasia can also occur. Necrotizing enterocolitis, retinopathy of prematurity, and adverse neonatal neurodevelopmental outcome, these are also seen with preterm birth. So, what are the causes of PPROM? One is intrauterine infection. This is the most common cause. Then oxidative stress induced DNA damage, this is also a cause for PPRM, and this causes activation of the placental adrenal endocrine axis. So, this axis is a hormonal axis, that means hormone secreted. So, due to the activation of this axis, there will be secretion of the cortisol, and that induces the preterm labor. Premature cellular senescence. Senescence means old age or degeneration. So, premature cellular degeneration. Which cells will be degenerated? The amniotic membrane and chorionic membrane cells will be degenerated. So, if cells are degenerated, the strength of the membrane will be less and there will be PPRM. So, what are the risk factors of PPRM? One is low socioeconomic status, more chances of infection will be there, low body mass index, nutritional deficiency, cigarette smoking and previous history of PPRM. These are the risk factors. Then diagnosis, again here history and examination. Sonography can also be done, but mostly by history and examination it will be sorted out. One is sudden gush of or trickling of thin fluid through the vagina. Many times during pregnancy, patient comes to you and complains that vaginal discharge is there. So, you have to ensure that whether this is a thin fluid or a thick sticky fluid and what is the amount of the fluid. So, if thin fluid and it is much in amount comes in gushes, then it is most likely liquor or amniotic fluid. If it is a thick fluid and very small in amount, then it may be vaginal discharge. So, by history also you can suspect. Then may be associated with pain abdomen and contraction may be there. So, pain abdomen and contraction if it is there, then you can very well diagnose that it may be onset of PPRM and preterm labor. Fluid, the certain characteristic of the fluid you have to ask and watch. One is consistency, as I have already told, thick consistency may be vaginal discharge. Color, it should be clear, it can be slightly cloudy or it can be yellowish, but if it is frankly red or green, it is different. If it is green, then it can be meconium. If it is red, it can be mixed with the blood. So, APS may be there. Then amount of fluid and time since leaking. So, this time since leaking is more important, because if leaking is very much prolonged, if she came after 2 days of the leaking, then in that case you may have to deliver the baby, because by that time infection might have set in. So, in examination you can do a speculum examination to see whether liquor is coming through the cervix or not. So, you can see through the cervix liquor draining or pooling of the liquor in the posterior fornix. So, these are the things you can see in the examination. So, if in doubt, we can do a pH test. Nitrogen paper is put. If pH is more than 6.5, it may be liquor. So, pH of vagina is how much? Can anyone tell? Rule 98. 98 is there. pH of vagina is 4.5 to 5.5. Okay. So, it is acidic. So, if something is adding to it like amniotic fluid or some vaginal discharge, sufficient amount of vaginal discharge, in that case the pH increases. So, if pH increases to 6.5, it can be contaminated with amniotic fluid. False positive may be there if blood, semen, bacterial vaginosis is present in the vaginal discharge, that can also increase the pH. False negative whenever there is small amount of leaking is there. So, in that case false negative can be there for this test. Other tests are there like arborization or Thorne pattern. These tests are not done nowadays. Nowadays clinically you have to see the liquor, or you have to do the sonography to see whether liquor amount is decreased or not. So, Liker seen, it is PPRM, Liker seen or not seen along with sonography substantial decrease in Liker amount, then it can be PPRM. So, in this test what is done, that fluid is put over the slide and dried it, and on drying it will looks like a arborization or like fern like pattern. Then detection of alpha fetoprotein level is much more in the amniotic fluid. So, if this level is more in vaginal fluid also, that is contaminated with Liker, then you can detect that she may be having PPRM. And in ultrasound you can see the amniotic fluid volume. If a few days earlier sonography showing Liker amount is normal and now it is substantially decreased, then it can be PPRM. So, certain point of the care tests are also available. So, one is Amnisure, it detects placental alpha microglobulin 1. So, if it is placental molecule, then seen in the vagina, then there must be some leaking of the membrane. Active PRM, this detects the insulin growth factor binding protein 1. ROM plus, this detects the both IGF BP1 plus alpha fetoprotein. So, the various markers are detected by this point of the care test. Point of the care test means those are done bedside only to detect PPRM. So, how to manage a case of PRM or PPRM? Hospitalization should be done, one to diagnose, again to keep the patient on rest and prevent any infection. So, you have to hospitalize, but after hospitalization do not do repeated PV examinations. So, more the times you do the PV examination, more infection will be introduced. Then monitoring of the temperature, pulse rate and uterine tenderness. Pulse rate is increased whenever there is signs of infection is there. Temperature is also increased whenever signs of infection is there. And you can use some of the investigation method to detect whether there is any signs of infection or chorioamnionitis. So, TLC may be raised, CRP may be raised, urine analysis may be detecting any infection, vaginal swab culture also may detect infection. So, if infection is detected anywhere in these investigations, you may have to terminate the pregnancy. Otherwise, fulminant infection of the uterine cavity and systemic maternal infection may ensue. So, management depends upon many factors. One is gestational age. So, at what gestational age the patient came to you? So, more early gestational age, more conservative management should be tried. Signs of infection is there, you have to deliver the baby. Signs of labor is there, already it is in the process, so fetus may deliver. Presence of cord compression, cord prolapse, abruption and fetal distress. These are the emergencies related to PPRM. So, in that case anyhow you have to deliver, maybe by cesarean section. Amniotic fluid volume left after PPRM. So, once the leaking occurs, you have to see how much left, how much amniotic fluid left inside. So, if sufficient amount is left and no infection is there, you can wait for few days or weeks also. So, here depending upon the gestational age, how you manage. If it is 37 weeks or later, you have to deliver the baby, need not wait for that. Okay. In that case, if any intraamniotic infection is there, you can treat it, and recent guidelines shows that at up to 37 weeks, you can give the corticosteroid for fetal lung maturity. Here at 34 to 37 weeks, expected management or delivery, both you have to consider, and any of the may be considered. That again depend upon whether the corticosteroid already given or not. If not given, you have to give it. Then any infection is present or not. If infection is present, then you have to treat it. So, you may have to wait for 48 hours till the effect of the corticosteroid starts. Corticosteroids, I will tell you in the next slides, those are the drugs given to increase the fetal lung maturity. So, fetal lung maturity, if it increases after delivery, fetus may survive extrauterine environment. So, this is more than 37, it is 34 to 37. Then 24 to 34, this is most crucial time, because here the fetus is not sufficiently mature for extrauterine environment without any assistance. So, expectant management should be tried and neonatology consultation should be done, corticosteroids should be given, and GBS screening. GBS means group B streptococcus, that screening should be done. So, if any infection is there, that has to be treated. Antibiotic is recommended because we are prolonging the pregnancy, chances of infection is very high. So, antibiotics should be given, and if any infection there, treat it and deliver the baby whenever there is any signs of infection, signs of fetal distress, or baby is sufficient mature for extrauterine environment. So, most important is the 24 to 33 weeks. So, less than 24 weeks fetus is mostly pre-viable, fetus may not survive extrauterine. In that case, either you have to deliver the baby or spontaneously it will go into labor. So, here you can see pre-viable fetus, what are recommended, what are considered. So, many things I have already discussed, like neonatal consultation, corticosteroid therapy, tocolysis, then neuroprotection by magnesium sulfate. These things I have not told yet. Neuroprotection by magnesium sulfate means magnesium sulfate infusion is given at gestational age 27 to 32 weeks, any time in between this, to induce the neuroprotection effect of the magnesium sulfate. So, fetus will not develop, will less likely to develop neuronal injury or cerebral palsy after delivery if you give the magnesium sulfate. So, antibiotics for PPRM, GBS prophylaxis, and cesarean delivery for fetal indications. These all, excepting the antibiotics, are not considered, are not recommended whenever it is less than 22 weeks. The more the early the PPRM, less options are there for the management. So, if same thing occurs at 24 weeks, almost all are recommended, and cesarean delivery may be considered or may be recommended depending upon the condition of the fetus. So, at 22 weeks almost not recommended, at 24 weeks plus it is recommended. So, that much you have to remember. So, clinical chorioamnionitis, how will you diagnose it? You are prolonging the pregnancy by conservative management. So, you have to know when to stop it. So, on onset of clinical chorioamnionitis, you can stop it. So, fever is the only reliable indicator for diagnosis of chorioamnionitis. Other things like tachycardia, CRP raised, TLC count raised, foul smelling discharge, those are associated factors, or those are not so much important significant contributor or causes of clinical or the indicator of clinical chorioamnionitis. So, fever means it is more than 39 degrees centigrade, or if it is between 38 to 39, and one additional clinical risk factors. So, what are the clinical risk factors? Low parity, multiple digital examinations, intrauterine fetal monitor, uterine and fetal monitors. So, you may keep monitor inside or the probe inside to monitor the fetal heart rate and uterine contractions. So, if those things are there, that also increases the risk of infection. Meconium stand liquor and certain genital tract pathogens such as group B streptococcus and sexual transmitted agent. Practically in our setup, this is more important, multiple digital examination. If multiple digital examination has been done, then there is more chances of infection, and in that case if the temperature is 38 to 39 also, in that case you have to think that it is chorioamnionitis. So, what are the antibiotics to be given? In PPRM or PRM, there are certain antibiotics are recommended. All the any or all the antibiotics you cannot give it. So, first thing is macrolide. Macrolide like erythromycin, azithromycin or clarithromycin can be given alone, or group B streptococcus antibiotic for group B streptococcus. What are those antibiotics? I will show in the next slide. So, macrolide plus antibiotic for group B streptococcus, or you can have a combination of ampicillin and macrolide. So, if you are screening for group B streptococcus, in that case you can use these two, or if you are not screening, then it is ampicillin plus macrolide or amoxicillin plus macrolide. That is the drug of choice for PPRM. So, this is the GBS group B streptococcus disease prophylaxis. So, prophylaxis recommended is penicillin G. This is an injection that has to be given every 4 hours, but nowadays this is not so commonly available and not practiced also, and alternatives like ampicillin can also be given. So, antenatal corticosteroids, as I have already told, it induces the fetal lung maturity. It should be considered whenever it is 23 weeks to 24 weeks. It has to be considered between 23 to 24 weeks. It is recommended you must give between 24 to 34 weeks. So, in between 24 to 34 weeks, if someone with preterm contraction, PPRM or threatened preterm, in that case you have to give the antenatal corticosteroid, and again it can be considered at 34 to 37. So, in between recommended, outside which it is considered. So, what are the corticosteroid can be given? One is betamethasone 12 milligram IM 24 hour apart. Betamethasone comes in an ampoule of 4 milligram. So, 3 ampoules of betamethasone has to be given IM 24 hour apart, 2 doses. So, if you are giving dexamethasone 6 milligram IM 12 hours apart for 4 doses. So, both these will be over by 2 days. So, by 2 days the drugs will be the administration of drug will be over. So, single course should be given, you should not give it repeatedly. So, if you give it more repeatedly, may chances increase of CP. CP means cerebral palsy. Rescue dose may be given whenever rescue dose means suddenly patient came with the signs and symptoms of preterm labor, and in that case already betamethasone given 1 week before, 1 week earlier to the incident, and when the fetus is less than 34 weeks. Suppose a 33 weeks pregnancy came to you with PPRM. So, you see whether betamethasone was earlier received or not. If it is received 1 week back, then you have to give it again. So, that is called a rescue dose. So, if it is given within 1 week of this incident, then you need not repeat it. So, that is rescue dose of betamethasone or rescue dose of steroid. So, what is magnesium sulfate for neuroprotection? So, it reduces the risk of cerebral palsy and substantial gross motor dysfunction in preterm fetus. So, RCOG recommendation is that 4 gram IV loading dose followed by maintenance dose 1 gram per hour for 24 hours. So, for 24 hours you have to continue the magnesium sulfate in a IV formulation. So, by giving this, the neuroprotection protective effect will be there. So, you have, while giving this one, you have to monitor the clinical signs of magnesium toxicity. So, you have to see for oliguria, signs of renal failure and respiratory rate, knee jerk, these things has to be checked. So, the prevention, most of the case cannot be prevented, like screening of GBS and bacterial vaginosis can be done, but by treating it, it is not preventing the preterm birth. Prophylaxis is not effective. Prophylaxis, as I have already told, encerclase, progesterone, although rapidly given progesterone, it is not so much helpful or not proven to be helpful always. Periodontal disease, although significantly associated, treatment failed to significantly alter the pregnancy preterm birth rate. So, overall you can tell that try for prevention of preterm birth is not so much fruitful. So, what are the take home messages? Till now we have discussed about the preterm labor, PRM, PRM. So, in all the three things, infection is the primary cause, and diagnosis is mostly by history and clinical examination. Rarely we need the investigative method, and management mostly depend upon the gestational age. Early the gestational age, more conservative management are tried. Later the gestational age, you have to deliver the baby. Corticosteroid, magnesium sulfate, antibiotic are the cornerstone in the management. So, preterm baby you have to give these drugs to increase the postnatal or post delivery survival of the fetus. Okay. Thank you. So, respond to your roll call. Roll 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. आज नहीं दिया ना अभी तक अटेंडेंस. 14 is absent.